Hello, everyone, and welcome to HeadWise, the weekly videocast and podcast of the National Headache Foundation. I'm Dr. Lindsay Weitzel. I'm the founder of Migraine Nation, and I have a history of chronic and daily migraine that began at the age of 4. Today is our monthly headache news episode with Dr. Tim Smith. Hello, Dr. Smith. How are you?
I'm doing well. Thanks for having me again.
Thanks for being here. We are always so excited when Dr. Smith is here. He's a regular on our show because of his extensive experience in migraine clinical trials. As the CEO of Study Metrics Research, he is also a board member of the National Headache Foundation. And we have a few really awesome new studies to talk about today. We do dedicate about one episode a month to the latest headache research, migraine or headache related medical publications or FDA approvals, etc. And we have a few things to report to you today. So let's get right to it. So, Dr. Smith, an interesting study was just published in Cephalalgia looking at the effectiveness of iranemab or Aimovig in people with what was called abrupt onset, unremitting, treatment refractory headache with migraine phenotype. I think most of us would often call that NDPH or maybe post-traumatic headache. So this was an important study because these are some of the people in our community who we really don't have much in the way of effective treatments for. So what did this study find?
So this study was done by a bunch of investigators at some Irish headache clinics, and in the UK, any patients with problematic headache are basically referred to these headache clinics, and they have them geographically located throughout the country. And what they did was they did chart audits to look at patients who had presented with this new onset of persistent daily headache disorder. And these were patients who went from basically they could have had pre-existing migraine, but it was not daily and unremitting, unrelenting, and or not, as the case may be. And they suddenly started presenting with, they could point to a day when this started. Some of it was traumatically induced, and some was not. And these are, as you pointed out, are patients that we don't have approved or reliable treatments, and so we pretty much try everything. If we're in the headache clinics, that's what we do, and that's what these Irish investigators were doing. And they identified 82 patients across their clinics, and they did chart audits on these. Their usual approach was to start with 70 milligrams of iranemab and then go to 140 if they didn't achieve 30% reduction in their migraine days after 3 months. And what they did was chart audits and looked at basically how they fared, and they did systematically in their clinics. They do quality of life instruments along with disability questionnaires and impact questionnaires. And the interesting finding from this in this highly refractory group of patients was that about a third of them, 35%, showed an improvement in their quality of life scores without side effects. And so we would look at that and compare that to our results on migraine studies, and we would say, wow, that's not very good, 35%, because we're used to seeing 55 to 65% responder rates in the migraine population. But this actually showed that as many as a third of the patients with this new persistent daily headache or persistent post-traumatic headache phenotype had basically got substantial improvement. So, and that is a significant population of percentage of the population for this group. So, sort of encouraging, tells us that it's sort of at least kind of opinion and consensus that it's worthwhile, trying a CGRP blocker on these patients and hoping for the best.
Right. So to reiterate what you said, that compared to the results in the strictly migraine population, it didn't perform quite as well. But for this group of patients, which is why I love to report these kinds of studies, because we don't get to report very often on things that are successful for this group of people. So it's so great to be able to say this. It did have about a 35%, or 35% of them showed improvements that were great enough that it improved their quality of life, which is a great thing when you are working with a group of people who are so treatment refractory. So I was excited to report that study on today's episode. Should we move on to the next one, or was there anything else on that study that you wanted to talk about?
I guess the only other thing was that they allowed patients to discontinue after 6 months. They tried to keep them on for at least 6 months. And so that's the 35%. And some patients persisted for a while longer, just electively, but they tried to if they didn't see a 30% improvement by 6 months after increasing the dose to 140 milligrams, then they let the patients opt out of that. So for clinicians out there, or for patients who are interested in this, it may take more than 1 or 2 or 3 rounds of treatment before you would give up on it. So if just a little bit of advice on sometimes we don't know how long to tell people to go, but this paper suggested that 6 months was a reasonable time frame to try it.
Okay. So those of us, we're going to move on to another study now that recently came out. So those of us who are severely impacted by migraine know that it can be very upsetting when our children are also diagnosed with migraine. So there is a new study that was released that looks specifically at children who inherited familial hemiplegic migraine. Earlier I said that perfectly. Sorry, that didn't come out right. Hemiplegic migraine is a rare type of migraine that comes with motor weakness as part of the aura phase. And so in this study, investigators identified kids who inherited this from their parents and then looked to see how it manifested in the children. So can you tell everyone what they found in this study?
Sure. And this was, so we're kind of got an international flair today. This is an Italian study, and which is great. And there's some respected headache specialists and researchers there. And they had identified a cohort of patients, 9 patients in these clinics in Italy. And they did a huge evaluation on them and did genetic analysis to understand if they had an identifiable mutation that caused their familial hemiplegic migraine. And we know there are a few subtypes that are identifiable, and at least 7 of the ones in this study had one of the 2 most common genetic defects that we know is associated with this disorder. And then they followed these patients for a little over 7 years on average, and to look at what their outcomes were like. And they measured things like attack duration and the number of attacks that the patients had. They found a wide variety on both of those measures. Some attacks as brief as 10 minutes of weakness they go with the headache, and some that lasted as much as 3 weeks. So when we say this is a complicated aura, it is, but this can be much longer than your standard 1 hour or less aura that we typically think of with the visual disturbance or the tingling sensations that some people may get. So this is, if you have a child that looks like they've had a stroke when they have a migraine and it lasts for 3 weeks, this is very serious and, scary. And you also worry about, what kind of damage is this potentially doing to their brains, and those kinds of things. And so these researchers did us a favor and followed these folks for a long period of time, a little over 7 years on average. And they showed that most of the patients with childhood onset of this familial hemiplegic migraine, turns out they experience infrequent and non-severe attacks that didn't require preventive treatment, and they tended to outgrow the problem over time. And I think very importantly, they also, over this longer period of time, they showed that no other neurologic phenomena or disorders occurred. and there were no signs of neurologic deterioration or injury. So these kids wound up having healthy brains as they went along. So that was, very reassuring. And I think there may be, parents out there with children who have this, so it'd be, very gratified and pleased to know the results of that analysis.
Right. That was what I liked about that study. That study was actually very encouraging. It was a little bit surprising, maybe, to see how well these children actually did, given that they had familial hemiplegic migraine genes. So I thought that was a great study, and maybe a little bit encouraging for some of these families, and also seemed like a lot of work. They followed those kids for a very long time. So
a big study.
Yeah. Another study, moving on. Another group followed some people to look at visual hypersensitivity in people taking monoclonal antibodies, which so many of us in the migraine and headache community are doing now. And the goal was to see if our visual related symptoms like photophobia decreased during treatment with the monoclonal antibodies, and to see if this was related to a decrease in other migraine symptoms. What did they find in this study?
Sure. So this group is from the Netherlands. They're quite notable group out of Leiden that have been on the front leading edge of a lot of migraine research for decades. And this group did a questionnaire study for, it was prospectively done, but it was a questionnaire study for patients that had been selected to go on either aranumab or fremanezumab. And this questionnaire was called the Leiden, let me read this so I get it correct. It's the Leiden Visual Sensitivity Scale, and they abbreviated LVISS. And being from Mississippi, I hope they pronounce that Elvis, but I don't know. If they didn't, they should. Thank you very much. And so anyway, they did this questionnaire at baseline and then at 3 months. And what they showed was that there was substantial decreases, significant decreases in the not only the ictal or the light sensitivity, visual sensitivity during the attack, but also in the what we call the interictal phase, which is in between attacks. And so that's a very instructive finding, because we do see patients with a lot of this. We call it interictal burden. So it's maybe a lot of things that are not going right while the patient's not having migraine attacks, in between attacks. And visual sensitivity can be one of those. And so being on a CGRP blocker looks like it benefits that symptom as well, whether or not patients are having a migraine. And we know that CGRP is involved there's some science showing that it is involved with the visual sensitivity piece. So this kind of ties that all together. So if it's involved, if you block it, then it should get better. And indeed it does. We do measure things like something called the most bothersome symptom. It's the most bothersome non-pain symptom with migraine. And we know that most of the modern treatments that we use do improve that as well. That's what we look at. And the one that's most common is photophobia or light sensitivity. But this study shows that interictal, if you do the test interictally, the scores improve as well.
All right, that is good news. I bet some people already knew that about themselves. They did notice that they weren't as sensitive to light when they started their monoclonal antibody medication. So that is an interesting study that we decided to throw in today. We do have one last one that we're going to discuss. This one's out of Australia. Until you mentioned it, I did not notice. We do not have any studies from the United States today. Maybe next month. So this one is out of Australia. A group found some interesting differences in hormone levels between people with and without migraine in a meta-analysis. Now, that means that they use data that was already published to run their comparisons. So let's talk about the differences they found, because they are pretty interesting.
Yeah, so they looked at a total of 29 studies that met their definition, and they this involved over 700 people with migraine and almost 600 controls. And these were studies that had information about estrogen concentrations, other hormones, progesterone, and then also testosterone in males, and also looked at cortisol levels, which we know is kind of our stress hormone that everyone has. And all of these are controlled by, they have a hypothalamic link, that is the part of the brain called the hypothalamus, which governs a lot of the automatic, rhythmic, and cyclic functions of our bodies. All of these hormones are regulated through either a direct or indirect link to the hypothalamus. And so looking at this would give us insight as to, sort of the general health and proper functionality of the hypothalamus, or that part of the brain, in our migraine patients. And they did find some interesting things. First of all, the estrogen concentrations in women were reduced in migraine in migraine patients as compared to controls, basically during what they call the luteal phase. This is the second half of the menstrual cycle. It's basically from ovulation leading up to the menstrual period. And those levels were reduced in patients with migraine, and to a significant extent when compared to non-migraine controls. There was no difference in progesterone, and in males there were no differences in testosterone. But when they looked at the cortisol levels, there's a diurnal change in cortisol. That means every day, kind of peaks in the morning and gets better overnight, it goes down overnight, and it basically is a response to stress. And they found that these levels of cortisol, the stress hormone, were elevated in both men and women compared to non-migraine controls. So the authors sort of surmised that this indicates some kind of perturbed hypothalamic function, or that basal part of the brain that controls some of our instincts and cyclic trends for our physical functioning. And it may have something to do with some of the day-night phenomena we have with when migraines begin. Also, we know cluster headaches are also, this is involved in that, abnormalities of that diurnal rhythm of cortisol. But this was looking at a strictly migraine population. So very interesting. It may raise more questions than it answers, but it certainly suggests that that there may be a basic hypothalamic abnormality that may be driving some of the hormonally related and stress related cycles of migraine attacks.
I think it is very interesting, but I think that one of the questions that some people watching or listening might be thinking is, how do we know that this variation or the differences in cortisol between people with migraine and people without isn't because I'm waking up in the morning and I'm so stressed wondering if a migraine is going to ruin my day. And so I'm wondering, do we know that? Is there something about this study where they know that, or is this something we just don't know?
Yeah, I think it's the answer is we just don't know. I didn't see anything from this study that really answered those kinds of questions. It's the typical chicken or the eggs, thing. So is having a migraine is stressful, and having stress, triggers migraines. We know for a lot of people, and so did the cortisol. Are these elevations up because these are stressed people that have migraine, or is it indicating some abnormality of the base of the brain that is lending to these attacks being triggered by stress? So clearly more work needs to be done, but and people are working on this. So hopefully we'll have additional news to share on that as more revelations come forward.
Okay. Well, thank you so much, Dr. Smith. This was very informative. I hope everyone found something that interested them. Thank you for joining us this week, and please join us again next week for the podcast and videocast of the National Headache Foundation. Bye-bye, everybody.